Wonderful. Good evening, everyone, and thank you for joining the ASPN and PSPS first comprehensive series on differential targeted multiplexed. We are so excited that you've joined us this evening. We are going to present our third session, which is session 3, focusing on the patient experience. We not only have an incredible faculty here tonight, but we are also joined by 2 wonderful patients who are here to share their stories as well. And we're excited to hear from everyone. So again, welcome to the program tonight. I'd like to introduce Dr. Kasra Mirdelfan. Dr. Mirdelfan, take it away.
Thank you so much, Michelle. Good evening, everyone. My name is Kasra Mirdelfan. I'm an interventional pain physician in Northern California. I'm also the Vice President of Clinical Affairs for American Spine and Pain Society, also known as ASPN. And I'm also the Vice President of Pacific Spine and Pain Society, known as PSPS. This is the third episode of a CME program on differential target multiplexing, which is one of the most novel technologies and the latest technology available in the field of spinal cord stimulation. We spent the first episode talking about the science that has gone into this and the decade-long scientific research from bench testing to animal testing to a randomized controlled trial and the results that we've seen so far. One of the most intriguing things for me about the science was the genetic expression that has been seen in the animal model with differential target multiplexing. And I can't wait to see where that's going to take us in the future with this type of technology. The second episode was with experts in this field who are engaging differential target multiplexing for their own patient population on a daily basis. And we talked about the workflow within their clinical practice. Tonight's episode, in my opinion, is by far one of the most important episodes, not just for this technology, but for neuromodulation in general. Over the past 2 decades, we've advanced over the past 5 decades, we've advanced the technologies in spinal cord stimulation far beyond anything we've ever seen before. And the last two decades have given us some of the best technologies on the market in spinal cord stimulation. But one of the biggest factors that gives us the best outcomes is patient selection. And tonight, we're going to hear from experts in this field and their own patients on how patient selection can really translate into the best outcomes. And without further ado, I'd like to introduce my co-moderator, Dr. Krishnan Chakravarthy, who really needs no introduction. He's a professor at UCSD, and I've learned so much from him already at his young age. And I'd like to turn the floor over to him for him to say a few words before we introduce our first panel.
Thanks, Kaz. You know, I'll just keep my comments brief. That was a really beautiful summary of where we were. You know, I think a lot of us have been waiting for this specific webinar, primarily because when Kaz and I first talked about this, when we first launching this concept, we really thought about how is this different and really wanting to hear from patients. And today, I think both Dr. Caparel and Dr. Josephson, who are really going to be excited about talking from the perspective of really understanding when we think about who the end person is that's getting these therapies, that's the most important. We all want to do best for our patients. That's why we got into medicine. And for those folks that are on tonight and those folks that are going to listen to this webinar, I think there's so many wonderful pearls that are going to come from it. So with that, I'm going to just kind of briefly, the agenda will be that we'll introduce the Dr. Caparel and Dr. Josephson and their and they'll kind of introduce their respective patients that they've brought forward. They're going to go through a little bit about what the care model and what they actually did from a clinical perspective, at which point Kaz and I will ask a few questions at the end of that, but they're going to also interact with their patients and do a little mini interview and kind of go through their experience. And at the end, after Dr. Josephson and his patient finish, any questions that may come up from folks on tonight, certainly Kaz and I will address it to all of our wonderful faculty and the patients that have really spent their time tonight, and we can't thank them enough, but super excited about this. So Kaz, go ahead and introduce our first faculty and patient. Looking forward to hearing what they have to say.
Oh, it's my pleasure. You know, this man really, you know, he's world-renowned, Dr. Leo Caparel from Carolina's Pain Institute. He's not only been a dear friend of mine for the past 20 years, he's contributed so much to our field. He's done more neuromodulation studies than anybody else I know, and he's been involved in a lot of groundbreaking research. But aside from that, just like the rest of us, he's got a clinical practice and he treats patients on a daily basis. We've asked him to bring one of his differential target multiplex patients online with us so he can tell us about the case and actually we can interview the patient. We got to meet Carol briefly last night and she's a delight, and we would just want to thank her for being with us as well. And with that, Leo, the floor is yours. Why don't you introduce us to Carol?
Thank you very much. I appreciate all of it from Aspen. Thank you for having me. This is such a nice occasion, especially talking about our dear patients that treat. And I've been sort of related to this therapy from very beginning, thanks to a friend of mine, Ricardo Vallejo, and such a phenomenal collaboration, mainly in setting up some protocols with the Stimulation and then later helping Medtronic efforts. But the therapy that we apply today and the patient that I'm going to introduce you just provides another evidence how this therapy works. We have now several of these therapies that are now exceeding 80% of the patients with more than 50% of the pain relief, and I'm really happy to be able to bring that, bring an example to you. Especially because this is not a common example of implanting a stimulator and looking at the outcomes. Mrs. Carroll was a patient for 8 years, and she came with a severe post-laminectomy syndrome. She has several microdiscectomies and menectomies that resulted in extensive scarring around the L4, L5 level, where she had back pain of discogenic nature, but also she had lumbosacral radiculopathy and a pain down the leg. She came with quite a bit of the opiates on board, combining at that time the fentanyl, transdermal, plus breakthrough oxycodone medication, plus membrane stabilizers, plus antidepressants for chronic pain. We did, like in any algorithm of the treatment of chronic pain, especially when it comes to post-laminectomy syndrome, you can imagine we trialed the transforaminal injections, the lysis adhesions, and went on and did a trial of this traditional spinal cord stimulation. That was successful. It brought up the pain significantly down and implanted the system, and she had a system that was going on until June of 2020, where the system, the battery died off, but system was already, we had lots of issues related to partial improvements in chronic pain. And I decided to switch the system and trial the rescue implant without trialing using differential target multiplex. So the implant was completed at the beginning of June, and improvements in the pain scores and functional capacity were so amazing that I would really love Carol to comment on it and tell us a little bit about her experience with the system. I'm going to just do a few more little lines when it comes to technological aspect. What we actually did, we placed 2 octrode leads at the top of T8 and mid portion of T8. We use already applied differential target multiplex waveform, and provided adjustment that took over the couple of days after actual surgical change to the system. She can tell much more about her improvements in functional capacity and pain. So I let Mrs. Carroll, if you don't mind, just telling a little bit about your experience with improvements in the pain scores and function.
Okay, thank you. I just after the surgery and after, the system was turned on, I was able to completely come off of the pain medications that I was on. And I have absolutely no pain whatsoever. And I am back to doing the things that I was doing prior to all these problems beginning. I do have limitations, but I've learned to live with those. And I can do anything that I want to do, and feel that I have my life back.
Carol, did it start with your the pain relief that you're feeling now, the kind of complete pain relief, which is really impressive, and congratulations to you for having that. Did it start right after the trial? What was the trial like? Can you walk us through your trial?
The trial, as far as prior to the permanent implant?
Correct.
Is that what you're asking?
That's right.
So Carol, let me correct this, the CAS. So he didn't have a trial with DTM.
Oh, I see.
I mean,
okay.
differential target multiplex. We just so we basically used the rescue therapy within a surgery.
Got it. I see.
The initial trial was with traditional spinal stimulation 8 years ago. So this is really nice example how the differential target multiplex can work as the rescue therapy for failed traditional spinal cord stimulation.
Oh, excellent. That's excellent. So you had traditional spinal cord stimulation before, the therapy was dwindling down, then Dr. Capral decided to use this technology for you instead. So actually that's a really good point.
18.
Okay. Go on, Carol.
Go ahead,
sorry.
Carol.
With the trial, I was able to reduce the pain. It was so much better, but still was not, I would say maybe 60% better.
Mm-hmm.
And we decided that with that much of an improvement, that it would be a good idea for me to go ahead and try the permanent implant. And so that we did. After the first implant, we were able to reduce the pain medication by 50%. I still had the fentanyl patch and the oxycodone when absolutely needed. And then when this system was put in, it was more or less of a gradual reduction of pain that happened. And I noticed that I did not need the pain medication. There were the space between taking those tablets kept getting farther and farther apart, until finally I just decided, well, I really don't need this anymore. And and again, there's no pain. I'm functional. I'm doing everything that I want to do, and life's been great.
So your expectation at the beginning was that you were going to get about 60% pain relief because you had that before with the previous device, which is actually what we see scientifically and in the general population with traditional spinal cord stimulation, is that about 50 to 60% of the patients get about 50% pain relief. So that's really remarkable. And just the need for the medication started to dwindle on its own, and then you just decided to stop the medication altogether. That's great. Now, do you keep the system on 24 hours a day, 7 days a week, or are you turning it on and off?
No, I leave it on all the time. It only takes probably, depending on how much of the battery I use during the day, it takes 30 to 45 minutes to recharge the battery.
Mm-hmm.
And I do that when I'm watching television. It's basically the same time every night. When I watch the news is when I recharge the battery, and it lasts, basically all day, the next day, and during, the night.
That's wonderful. So I take it that you don't get to see Dr. Caporal as often as you used to.
No, that's the downside.
And that's okay. You know, I said it's better. You know, I love Carol, and we know it for such a long time, but it's better not to see me.
Yes.
That's right. That's right. Dr. Chakrabarti, do you have any questions for Carol at all?
So I have a question. Carol, I'm just so happy for you that you've gotten such wonderful outcomes. You know, I wouldn't expect anything less from Dr. Caporal. You know, one thing, you know, we as physicians sometimes would love to hear from patients of the experience that you had. What was the most meaningful thing that was a difference in your life? Was it reducing the medications? Was it really getting to improvement in your pain, or was it really just getting to more activities? What really stood out in the experience from the entire process that really said to you that this is what was, I'm so glad I did this, and this therapy really has made a big impact?
For me, I think it was the entire package. I was looking prior to this and meeting Dr. Caporal, a life of excruciating pain, not being able to do the things I wanted to do, being dependent on a walker in order just to be able to get around and to function. And I thought that was going to be my life. So I was just, I think the thing that really hit me the most was the absence of pain, because I had lived with it for so long and it affected my whole outlook. There's no joy in pain. And so that, I think probably the biggest thing for me was living without the pain.
Yeah. Your story is so compelling, mainly because of the fact that, first of all, you're getting the kind of, you know, optimal pain relief that we all hope for our patients. But the fact that you had an experience with a different device in the past, and you've been able to graduate to this, and you understand it and you enjoy it so much more because of your previous experiences. Now, Leo, I have a question for you about Carol. You know, so rescue therapy is big. We've been talking about it quite a bit at various scientific sessions and all that. What was it about Carol's whole persona and presentation that really brought you to the point that you thought, well, maybe I should try this patient for a rescue therapy instead of abandoning SCS altogether?
Great question.
Yeah, I mean, first of all, I thought about the improvements that she had before. And second, the nature of the pain that she has. She has post-lamic classical radiculopathy, significant component of neuropathic pain, and some discogenic back pain at the same time. And Carol has a few other medical problems that we don't have to discuss now that we would like to have 100% MRI compatible system. And those add up when we decided to go with the switch. What it was a right to do. I think that we have now experience in the patients that exceeds 16, 17. And I feel that it's very hard to hit every time a jackpot. But if you hit it 16, 17 times, then you say, well, we now graduated to much more effective therapies that we have to move on. You know, in pain world doesn't happen that fast. You know, our colleagues in cardiology and something, the new therapy exceeds 80% of the pain, 80% of success rate, I'm sorry, then will equal to 80% of the pain relief in our area, they would move on. And that's what we have to do. We have now several therapies that are highly effective and provide such a profound relief of pain over extended time period. So I feel this is a good example for it.
I got a follow-on question to that, Dr. Caporal. So one of the challenges for a lot of young clinicians graduating from fellowship is, how do you really describe the unique value of these therapies to our patients? And Carol, Dr. Caporal did a great job really talking about the differences between the stimulation therapy you had before to what he was going to introduce you to. Kind of walk us through a little bit of how did you guys, where did the educational piece really play a big part in convincing Carol about continuing to trial a different therapy, and just kind of the challenges and the things that you guys wanted to hear in that process? I think it's really important for a lot of clinicians to kind of want to hear, especially given your wealth of knowledge with so many different platforms.
Chris and Cass, I don't know much more than you do as far as evidence-based literature that we have out there. And we do have decent studies, very large studies now looking into outcomes of the several of new waveforms. I try to follow and I try to implement this in my clinical practice, and results are good. Results are great. Same as with a few other therapies that we apply in the past. And I think we are moving very, very fast forward when it comes to neuromodulation for chronic pain. Following this, I think it's the main thing for somebody who, when you're mentioning somebody who just graduated and is building their practice, because within the community, within the area where they practice, they're going to distinguish themselves based on outcomes, based on patients having profound relief pain, like Mrs. Carroll had. And I think that's probably the way to go. 1, 3, 5 cases that you do using any therapy doesn't mean much. You may have 3 or 4 good runs and then have lots of bad runs, isn't it? But I think that the experience of overall community of the pain physicians across the country and in the world depends mainly on evidence-based literature, and even specifically on higher level of the evidence, like the studies that are provided and we can definitely have access to.
Wonderful. There is one question from the audience. I just want to invite the audience to enter their questions into the Q&A panel. And the question is, I was under the impression that DTM therapy had to be for SCS naive patients only. So Carol is a rescue patient. How is that related? And the answer is, I think that the manufacturer of this technology is encouraging people to use naive patients first, so they can so the physicians can get their feet under them, they can understand the technology better. But this technology is not exclusive just to SCS naive patients. It could certainly be used as rescue therapy as you understand the technology and the science better as well. Krish, do you have anything to add to that at all?
Yeah, and I think one thing is part of that, and Dr. Caporal can kind of elaborate on this. He's mindful with the DTM, differential targeted multiplex, in terms of the care delivery, just being mindful of the anatomical placement when you're trying to salvage another system, because certainly the programming options are consistent with where these leads are placed. So, Dr. Caporal probably went through that systematically for Carol to try to give her the best chance of succeeding with DTM. So I don't know if you wanted to elaborate on that, but Leo.
No, that's a very good point, because they differ. Now, we differ from traditional type of the spinal cord stimulation by placing the midline leads at what we call fluoroscopical midline. Everything else is the part of the complex programming. And but the outcomes, as you can see from the study that was announced only 2 weeks ago, 12 months data, which is, to me, long-term data from the differential target multiplex. In my experience, initial experience with Stimgenics suggests that the therapy is here to stay. It provides sustained long-term improvements in pain and functional capacity, as you can see what Mrs. Carroll testified in her own case.
Wonderful. Well, thank you so much, Leo. Thank you so much, Carol. You guys were amazing. We really appreciate you joining us tonight. And you've enlightened us quite a bit. Please feel free to stay along just in case there are any questions at the end. But at this point, we'd like to invite the next panel over. Krish?
Yes, so I get to introduce my close colleague, Dr. Joe Josephson, who probably needs no introduction either. I think he's a true social media star, as he would like to, probably would love that compliment, but it's because he puts out wonderful content, really educational content. And I think when we had spoken to him about this, I think he's super excited. So I'm going to let him come and introduce his patient, Debbie, and really looking forward to hearing this conversation. So Joe, take it away.
Thanks, Krish. First of all, I want to thank ASPN and thank you guys for inviting me and Debbie here to speak tonight. You know, when I was asked to do this, this was one of those like moments where, you know, we've all been doing, you know, quite a bit of these Zoom conferences and, you know, been on a lot of meetings. And this is one that I actually truly got excited about. You know, very rarely do we ever get the opportunity to not only talk about a therapy and a modality and our experiences with it, but to actually invite a patient out to be on camera with us, to actually discuss, you know, not just my experience, but their own experience with the therapy. And I think ultimately this is going to be probably one of the best teaching Zooms of the year, I'm sure. So, you know, it was funny when I heard, also when we were kind of prepping for this, I heard, you know, I was going to follow Dr. Caparol, and I was like, oh man, I get to follow Leo. And then I realized that the real star here was Carol. I mean, oh my God, I got to follow Carol. I mean, so without further ado, I want to introduce Debbie. Debbie is a wonderful patient. She is someone who I got to meet back in 2017 after she had suffered a pretty serious car accident. She was she was a driver in a head-on collision back on October 28th of 2015. I saw her a few years later and we attempted, you know, general pain management. I was lucky enough to meet her before she got to the point where she was on opiates. And when she first saw me, one of the first things that she told me was, Dr. Josephson, I want my function, but I want that functionality without a pill. And that was something that I took very serious in my care for her. And after we tried a couple interventions, I basically threw my hands up and said, listen, your pain is, you know, your classic radiculopathy. You know, it might not be a bad idea to see a spine surgeon, which she did. And then she subsequently was decompressed on June 29th of 2019. She underwent a laminectomy infusion and she returned back to me with continued pain. What was interesting about her though, was the surgery actually worked for her. She presented with mostly axial back pain. She did not come in with, you know, your classic, you know, stim symptomology. She came in with mostly axial pain. So, you know, I went to basically your axial pain generators after surgery. So we tried an SI joint injection, placed her on some Lyrica, and she had some minimal improvement, but she continued to say, you know, I continue to have this pain. I continue to have this pain. And it was around that time that I had learned about differential targeted multiplex and how there is some initial improvement with back pain. And I thought, you know what? This would not normally be a patient where I would jump right to SCS, but I thought, you know what? Let's give it a try. So we set up a trial, and that trial was performed on August 31st. And actually, I think this is where, you know, I can talk for hours. You guys all know that. There is no shortage in my ability to talk. But this is one time where I think I just need to shut up and let Debbie talk. So Debbie, how are you?
I am good. Thank you.
Her voice is even much better than mine, you know? So why don't you tell me, what was your experience with the trial? What did you think?
Wow, the trial opened the doors for what my future could be, you know, because after living with such chronic pain for so many years, and having a spine surgery and still was living with pain. Doing that trial, I think I did say to you, if I could have this with the implant, I'm ready. Okay, hands up, I'm ready. So it was the best relief I've had in years. I was able to do things that I was unable to do, literally. And the things that I was able to do, I was able to do them even better with my trial.
So,
go ahead, I'm sorry.
Go ahead, Joe, go ahead.
No, I was gonna say, when she presented to me, she basically, when she came in for her trial, it was one of those moments, you know, as a doc where you think to yourself, you know, you want to do like the Rob Gronkowski, you know, throw the football into the ground. You know, it was, you know, because again, this was one of those situations where I would not have traditionally have chosen an SCS, certainly not after, you know, an SI joint injection and a medial branch block gave her minimal relief. But the fact that I had the option of using differential targeted multiplex in this particular patient really was kind of game changing for me. And I would say game changing for Debbie. So she basically more or less begged me to keep the trial in. And when I explained to her that I can't do that, that I would have to, we'd have to go through and do an implant. So we did subsequently implant her, and I'll let her talk. So far she's been doing, what would you say, Debbie?
I am doing great so far. I am still able to do things that I was unable to do, and doing things that, for example, I have been wanting to rearrange my bedroom. And every time I look at it, I'm like, nope, not doing that. Nope, not doing it. And I went to work on Sunday. I charged up on Saturday morning. I worked on Saturday. I worked on Sunday. I came home on Sunday evening and I looked at my bedroom and I'm like, yep, I'm going to do this. And I got in there. I didn't need to recharge. Okay. I didn't need to take any painkillers. And I went in and I started to move things around. Of course, I got them on the sliders and I slide things around, but I was able to take on the task of saying, rearrange my room. And I started that Sunday evening and I completed that yesterday. And I only took a painkiller yesterday because I'm like, Debbie, you don't want to overdo this and feel any form of pain. So I took a painkiller in the evening before going to bed. And this is still me. So I was able to take on that task because of my implant. So I am a whole lot more improved than I was prior to this.
And if I could just throw out there, if you don't mind me sharing what painkiller that is, just for the audience who may, it's what is your painkiller?
My painkiller is tramadol and tizanidine. That's what's on my bottle. Okay, that's correct. That's tramadol and the tizanidine.
Yeah, so
and I have the other one.
Yeah, she's only been on, the strongest thing she's been on is tramadol, which she takes, you know, very, as she basically stated herself, very sparingly. So, you know, this is one of those instances where you really see real time here. You know, this is a young woman who works full time as an, I can never say this word, an
esthetician.
And, you know, she's bending forward, doing, you know, a lot of the work that she does. And, you know, it's pretty amazing to see those kind of functional improvements in terms of, you know, quality of life and the ability to not just function, but function at a high level, working and doing these things. So it's been a pretty amazing experience.
It must be really satisfying for you, Joe, to be able to see your patients do this well. Debbie, I have a question for you. So for your trial experience, you know, as when Dr. Josephson told you about it, and you went into the operating room and you got the leads placed, how long did it take you before you started to actually feel some pain relief during that trial? Was it a day, couple of days? Do you remember at all?
In all honesty, whenever I do get anesthetic, it takes me about a day or two to say, okay, I am out of it. So I did take that day or two just to really rest, to give my body the okay. to start feeling what it is supposed to feel. So after day 2, I got up and I started moving around. And that's when I realized that, but hey, this is really working. So I went out there, I was told, you know, you are going to need to see if this is working for you. And I took that literal. So I decided if I will have to give my doctor a report about how it worked, the only way I can know that is if I attempt to do things. So I was mowing the lawn, I was rearranging my garage, I was cutting the backyard, I was pruning the trees. I dove in and I did things, okay? And I went to work still. And my workbook, I'm usually very booked. I'm booked hour on the hour back to back with my facial clients. And as he says, I sit and I am working over on clients and I'm doing their massages and doing their skin. So I really push myself to the limit. So after day 2, I was up and about. And when I had to go in to remove it, I was in tears. I did not want to remove it.
So I have another question for you. These back-to-back facials, were any of them Dr. Josephson? Because we all wonder how beautiful he is. You know, do you have anything to do with his facials?
Yet. I'm still waiting. You know, he's so busy making his patients happy that he hasn't gotten a chance to see me yet.
Listen, we haven't talked about facials. We talked about oxtail. And
right, and curry goats.
And curry, that's what we've talked about. We haven't really talked about facials.
So I have a question for you, Debbie. So I mean, both of your energies are so contagious. I mean, I think you guys are such wonderful advocates for this therapy. So for a lot of the patients that are out there, sometimes there's a lot of fear with some of these type of implantable therapies. How did you and Dr. Josephson work through that? Like, what were the big kind of challenges you saw and kind of what made you feel confident that this is something that you wanted to try?
Well, as he said, when he spoke to me about it, the very first time, he was detailed. And I am a very reserved person. I would be like, you could talk all you want, but So I really listened to him because I trust him a lot from the minute I met him. And I listened keenly to what he had to say. And I took what he gave me home and I read into it and I thought about it and I said, what do I have to lose? You know, so the mere fact that I trusted him, that's the number one thing. Because I don't think he would have been encouraging me about something that wouldn't help me, knowing the condition that I have been in. So because I trusted him, that within itself, apart from reading up and getting more, knowledge on it, is number one, what made me decide that, okay, I am going to put my body in his hands. So yes.
Right. So just to kind of, just for, some of the younger docs who are out there, the reality is that it doesn't really matter how great a modality is. It can be the greatest thing in the world. It's just like in the business world. It doesn't matter how great a product is. If you can't sell it, if you can't put that product into someone's hands, it doesn't matter. So when it comes to SCS, having the ability, having that knowledge base to choose the proper therapy for the proper patient is paramount, but also having that discussion with that patient, gaining that trust, having them understand and don't, I treat every patient like they're a clinician also. I explain to them, we're going to put this piece of, it's like a piece of spaghetti. It's an epidural injection. Instead of putting in medication, I place a wire in and you're going to wear it for a week. When you come back to me, I take it out. It's like, I actually say like, hey, would you buy a car without test driving it? I certainly wouldn't want to sell you a stimulator battery without you testing it. So I give them that information to just say, look, this is a procedure, but it is an opportunity for you, and one of the few opportunities in medicine to actually be able to test something out before you actually have it implanted. I say it all the time. Like if there was an ability to do a trial for spine surgery, I wonder how many people would actually go through it.
I know. I say that too. It's so true. Yeah.
So it's one of the few times where you get to test drive it. I mean, and it's an amazing the trial in and of itself, I mean, it's imperfect, but it is absolutely a beautiful thing. And we did table test. I'm a big fan of mapping. I think it's vitally important that you wake the patient up and you do map, so that if if for whatever reason, whatever modality or whatever waveform you're thinking, you have that flexibility to go between waveforms, to go between modalities, to go between therapies with the same battery, which again, the Intellis battery gives you the ability to do that. I did place the leads over midline between 8 and 10, and I did mapping as well. And I also took the extra step to ensure that the leads did not migrate during the trial. So I had her actually get up and flex and then return to the table and take another image. And again, I think that's textbook. I'm not sure if everyone does that, but as my first patient, as one of my first patients utilizing DTM, and especially since I think Debbie is such a remarkable human, that I really wanted her to have the best outcomes. So I said, if the outcomes were great in the study and this is what they did, I might as well do that as well. So I just kind of kept to that recipe, and sure enough, she did great.
Joe, that's a really segue to one of the questions that I had for you. Lead migration has always been an issue. Probably one of the biggest issues is spinal cord stimulation throughout the years. And I know that precision placement of these leads is really important for this type of technology. Have you had issues with lead migration? Have you gone back to revise any patients so far in your hands with this technology?
Well, I will say that, all of us, lead migration is an issue, especially during trials. I think during the implants, anchoring is a much more secure. If you're doing your own implants, for sure, you probably have figured your skills out to be able to place those leads and not have them migrate as much after an implant. Certainly, I just want to go back a little, because Debbie said she was mowing the lawn and doing all these things during the trial. I usually say for the first few days of the trial, avoid bending, twisting, and lifting to avoid that lead migration. But and then, at the end, if you just know how you feel with it, and then, start to increase your activity. But, like I say, you let somebody, walk, expect them to run. And that's basically what happened here. Lead migration is an issue. I usually will check an X-ray. I have fluoroscopy in the office, and usually when I remove my leads, I will get an X-ray. I know a number of my colleagues do the same, because again, you start with an image, and your image usually is a little bit different by the end of your trial period. I also think what you secure with, I used to use StayFix to secure, but I didn't love what would occur underneath the StayFix with the sweat. And so now I just use, Steri-strips and Mastisol. And, but I think it's important at least that you, especially with your larger patients, when you have patients who have, like Philadelphia specials, you have some large patients, and, the bread's good here in Jersey and PA, you can't blame people. So, I mean, you can, I guess, but a lot of times the leads move, and it's pretty amazing. You secure it, I put sutures in, and sure enough, you get them up, you flex them, and they lay back down, and you got two contacts, displaced. So that is something I think we all struggle with, and so I just try my hardest to just fasten these things down well, and I don't usually go back in once everything's taped up and revise it again. We just kind of consider the trial where it is, but you hope your mapping continues. And if I have had situations where a patient has gone out and we've lost coverage when they do test, and I will bring them back and revise it again. I just think that's the right thing to do.
That is the right thing to do.
Yeah, most insurances will only pay for one trial, and if you get one shot at it, and if it moves and they're still in the OR and they're still in the facility, you bring them back. It's just the proper thing to do.
Wonderful. So, Dr. Chakravarthy, do you have any questions before we go to the audience questions?
I guess no, I think that was really well stated. So maybe I can ask the first audience question, because I think it's relevant. Sure. There are different programming options, Joe, for this. Obviously, can you kind of walk us through what Debbie had done from the differential target multiplex programming, and which one was there any preference of one option versus another?
I mean, so I can tell you that she went through, she primarily went through the main programming algorithm. She was one of those people who really took to it almost immediately. There has been a little bit of variation. So that in the trial, it was basically a slam dunk. She went right into the, the standard protocol and basically stayed there. She was like in program A and stayed in program A pretty much all the way through. There have been, so since she's been implanted, there has been a little bit of reprogram that has had to occur, but I assume that's because of scarring that is occurring and some of the changes that occurs after the stimulator is placed. I think, when it comes to programming, having the flexibility to be able to program and try different waveforms and try different things is really vitally important. One size does not fit all. And when you start with DTM and having the kind of flexibility to go back and forth between modalities is probably what's the most important thing when it comes to programming, to not just be kind of pigeonholed into one thing per se. So.
I guess the next question from the same the physician is that has Debbie changed her options and preferences over time with DTM? Debbie, are you using the same program or have you changed your options or do you play with your remote control at all?
I do go through, or rather I did go through. So initially I went through the options so I could see where I am most comfortable. And after the reprogramming, I went through them again to see which one is the best one for me. So I have found my comfort zone and that's where I am at.
Got it. And do you keep it on 24 hours a day, 7 days a week, or do you turn it on or off? You do.
Absolutely. I watch that remote. As soon as it says it's getting low, I charge again.
Got it. That's
excellent.
excellent.
I do not want to experience life without it, because after my trial, when I went in and it was removed, I came home in tears.
Well, that's incredibly profound. Excellent
in pain, tears. So yes, I keep it on 24 hours.
Joe, the next question is for you. Dr. Lee is asking if there's a difference between lead placements between traditional and differential target multiplexing.
So you really want to have the leads midline between 8 and 10. I also stagger them between 8 and 10. But again, I'm also mapping. So the mapping is going to be probably what the most important thing for me is. Ultimately, if it's a patient who, has bilateral extremity out of the foot, and the only way you can get that is at 11, 12, I usually will leave it there. Because again, it can't be one size fits all. The thing that with some of the other systems, when you had, you just placed the leads, patient was asleep, they woke up and their leads were placed. The issue was sometimes when you did have to place them into a traditional or a more traditional stimulation or more traditional waveform, the mapping hadn't occurred. So you really didn't know where, what you were stimulating per se. So ultimately I like to, you want to place them optimally midline, staggered, mid T8 to T10. But again, I also do map. So that is ultimately where I want them.
And do you use the anchors, or do you suture to the leads, and where do you place your IPGs typically?
So typically for implant, you mean?
Yes, correct.
Yeah, so for implant, I usually will anchor to the fascia. I'll go down supraspinous fascia, place it right there. I use the Medtronic Stay Fix anchor. I don't know if people like that anchor or not. I happen to love that anchor. I am somewhat agnostic. I will use everybody. I don't have any. I use all the companies. I'm not like someone who says, oh, I will never use that or that. But I will say that the anchors for the different companies are very different, and you can have preferences or not. I happen to think the Stay Fix anchor is a pretty good anchor. So what I normally will do is I'll place my leads while the needle is in. I will then place one silk suture anchor, tie that, and then place another one. I usually would use at least two pretty heavy silks and tie them down. And then in terms of like where the IPG is, I usually leave it to patient preference. If they sleep on one side versus the other, The other thing to consider is, if the patient has to charge this thing and they have a bad shoulder, they may not be able to get it behind to be able to go. So you may want to place it a little bit lower. So keeping those things in mind and not having it in the belt line. But as one of my colleagues once said, he doesn't ask where patients want their IPG anymore, because no matter where it goes, it always ends up being uncomfortable. So he does it by his own preference. But I will say that there is something about the size and the flatness and how deep you can place that Intellis battery. So traditionally, you need to be about 1 centimeter in depth. With the Intellis battery, you can go up to about 3 centimeters, which is pretty, it's a lot of tissue, and that's a lot of cushioning. And that cushioning is going to be to the benefit of the patient and their comfort at the end of the day. So, yeah, I'm pretty much pretty standard in how I do it. And for all the younger guys, again, find a way you like to do it and just keep doing it that way. Don't try to
Sounds good. I need to come and do a preceptorship with you sometime.
I was gonna say I should come do one with you, man.
Maybe we should bring up
much nicer
Carol on too for the final.
That's right.
What's that? Yeah,
we should totally do that. And while Leo and Carol are getting back on, Dr. Chakravarti, I know you have a lot of experience with this technology yourself. Not to mention the fact that you've contributed quite a bit to this scientific strategy with differential target multiplexing. So why don't you answer this question that Dr. Malik just asked the question. It's in the, it says, what do you tell the patients? So how long do you try one program before you switch to another one? Do you keep clicking through the remote control? How do you find out if a program is helpful? So I think the question is, how long do you wait before you switch programs around?
Yeah, that's a really good question. So, I think a couple of things, that certain parts of the programming has a lot to do with the lead positioning. You can essentially preclude from running certain of these. So there's 3 specific programs, A, B, and C. And you may lose certain programming options based on if there's any suggested migrational issues. To me, I get back to, typically the wash-in period, there's no hard science per se that, as we're kind of getting a larger and larger patient demographic of patients, how many are, and what's the expected time for response. But 24 to 48 hours, you should see some effect. The challenge is that, and this brings back an important point, if you're switching through these different programs and you're not seeing the effect, then one needs to be mindful that when you're thinking about anatomical placement as a feasibility and the kind of the groundwork that laid to getting it in that sweet spot, should you be imaging somebody again before you conclude that they're not responsive? And that's really important, because that's a totally different way of thinking on the workflow, right? Essentially, you're saying, look, I can run through these different differential target multiplex programming options, but before I say that person is not a candidate and I can go to the traditional low density or high density stimulation, I highly recommend getting an image. I know that, certain vendors may not require that, but with this therapy, I really, I feel strongly that that's worth getting that data before you essentially say that that patient or candidate is not a good responder to the therapy.
Excellent.
I don't know if Dr. Josephson and Dr. Caparel want to add to that, but that's been my experience with all my patients.
It depends on therapy, but yes, with this type of the therapy, definitely that's the time frame.
Excellent. There is one question from Dr. O. It's how does this therapy stimulate glial cells differently than traditional tonic stimulation? Well, Dr. O, we did a whole hour of a CME program on this very topic. That was our first episode. I would really encourage you to go back and watch that, because it's going to cover it a lot better than what we can do here, along with a PowerPoint presentation and the experts in this field, including Ricardo Vallejo, who actually came up with the technology. So with that.
The 2 articles, yes. The 2 articles on Centeno Vallejo that were published, and they detail this potential approach. I think it's really good read. And
I'm trying to plug my CME program, Leo.
I'm sorry about it.
Yeah. No, but before I give Dr. Chakravarthy the last word here, I just want to say how remarkable it is, because before tonight, we knew that Dr. Josephson and Dr. Caporal were going to join us. We knew that they were going to bring patients on. We had no idea how dynamic this entire apartheid was going to be, and how remarkable it is that these two patients, being in two different parts of the country, have some similar outcomes with the same technology. It's very empowering for me. Before I turn the table over to Krish to bring us home, I just want to thank everybody for joining us, especially Carol and Debbie, because you really made our day. We see a lot of chronic pain patients. Our goal is to make them better with everything that we can. And we hope that we can get a lot more patients like you in our practices as well. Dr. Chakravarthy?
Yeah, you know, it's fascinating. At the end, we'd spend so much time. It's a humbling thing when you're in medicine, because you learn so much about who you're treating and the things that are meaningful to them. And I can't thank Carol and Debbie, because it gives us really a lot of energy to feel like we're contributing something to make a difference in somebody's life. So, you know, thank you for taking the time. I think everybody who is a neuromodulator should be thinking about really understanding what's important to our patients. So I think that was really highlighted. You know, I like Kaz and I talk about every time we get on these webinars, it's as much a learning experience for us as much as we were trying to moderate this. So we had an amazing faculty today, as well as their wonderful patients. I think we have one more session that we're going to try to do on the 3rd of December. That's going to go through kind of speaking to the investigators on the RCT data that was just recently, the data was released on a global platform. So looking forward to discussing that. But you know, this is a great job that we have. I just really enjoy interacting with such wonderful thought leaders across the country. And it's just really fun to moderate these sessions with Kaz. So.
Absolutely. And thank you, Leo and Joe, for joining us. It was awesome having you guys on.
Yeah.
Excellent. Well, Krish, I'll see you on December 3rd. Same bad time, same bad channel.
See you guys.
Bye, guys.
All right, guys. Have a good evening. Bye-bye.
Good evening.